Well, thank you very much for inviting me here to come here and meet you today and for me to share my experience on Huntington's disease, both from a clinical perspective but also as a scientist. I've been involved with Huntington's disease research for more than 21 years now, and I worked in an HD clinic for 10 years. I'm very privileged now to have a very exciting job as both as a professor in neuroscience, running a research lab looking at molecules and disease mechanism of Huntington's disease, as well as being a senior consultant in psychiatry, running an HD clinic every week at the Lund University Hospital, where I see family members with Huntington's disease at all stages. So, the talk today, I'm going to talk a little bit about, continue to talk about a little bit about the exciting history of Huntington's disease and take you with me to the gene hunt in Venezuela. I'm going to talk a bit more in detail about the different clinical features of Huntington's disease and describe the different treatment options we have available today. I'm going to mention what we're doing at the Huntington Center in Lund, Sweden. And then I will go on and talk a bit about the disease mechanism in the brain, mainly the ones potentially underlying the psychiatric symptoms that I'm mainly focused on, and touch also on future therapies. So we heard Lauren talking about George Huntington, who described Huntington already in 1872. But I could have been here talking about Lund's disease. One of the Norwegian geneticists told me that John Christian Lund, a Norwegian clinician, actually described Huntington's disease, or chorea Sankt Vito, as it was called, already 1860. And so Lund's disease, of course, would have been particularly fun when you come from Lund University. But as was mentioned, it was known early on that this was a hereditary disease, and in fact, by some chance, or potentially because there was a Norwegian sailor who came to Lake Maracaibo in Venezuela with Huntington's disease gene and then had many wives, there are many people affected around the poor shores of Lake Maracaibo in Venezuela. And that was known in the 60s and 70s by some major clinicians in movement disorder in the US. And they, together with Nancy Wexler, who grew up in a family with Huntington's disease, started to go to Venezuela, and they made these pedigrees of all these generations, 13 generations they collected, of people affected by Huntington's disease, and collected blood and sperm and really characterized these patients. And that was part of the material that was then so helpful in finding the Huntington's disease gene. Okay, anyway, so the people in Venezuela were also some of the early research heroes, really contributing their history and their blood and all the information that led to the finding of the HD gene. Oh, now she's coming. Okay, so this was these poor areas. These poor people lived on the trash, literally. And when you walked around, you saw men like this man here affected by Huntington's disease. And so we went around on the shores of Maracaibo, visiting all these families affected by Huntington's disease. And also this man here with end-stage Huntington's disease, really showing this typical weight loss and cachexia that many people are affected about, and also indicating that there's also some metabolic dysfunction in Huntington's disease. And so this led to the discovery of the Huntington gene. As you know, Huntington's disease is always caused by an expansion of a CAG triplet repeat in the Huntington gene. And so we say that more than 40 leads to Huntington's disease, 36 to 39, there's a risk of Huntington's disease, and below 26, there's not HD. You see there is a gap here with the repeats, and there are actually some intermediate repeats between 27 and 35, where you may or may not get some symptoms. There's a bit of a debate on that, but those are the expansions that can expand to the new generation, probably causing the around 15% of what we call spontaneous mutations. People who manifest with Huntington's disease without having it in the family before. That probably comes from those intermediate repeats. And so, as we also heard before, is that there is a clear relationship between the number of CAG triplet repeats and the motor onset, right? And so, as we've heard also before, there are a lot of psychiatric and cognitive symptoms before that I will come to, but at least there's this correlation with motor onset. But this is true when you look at the group level, when you have the individual in front of you, as you can see here very clearly. Somebody with 40 CAG repeat can manifest at the age of 20. They can also manifest at the age of 17, 18, and I think that's really important to remember, and many of our colleagues don't know that, and also the patients, because they typically think, yes, it's between 30 and 50 years of age, that's when I'm gonna get the disease. And again, just showing here that there's around 50% explanation of the age of onset based on the CAG triplet repeat, but there may be other genetic modifiers as well as environmental influencers that we're trying to identify. So it's a hereditary disorder affecting families, and it's autosomal dominant, meaning there's a 50% risk for each child if the parent is affected. It has a full penetrance over 40, that at some point in your life, if you have the expansion, you will get the disease. And unfortunately, it also goes with anticipation, meaning that it tends to get worse. The CAG repeat tends to get more if it comes from the father. And we know today the pre-symptomatic genetic test is made by only around 15% who don't yet have any symptoms. And that's true for many or most countries in Europe and North America. So Huntington's disease, yes, it's a real triad of psychiatric symptoms, cognitive symptoms, and motor symptoms. And I think what's really important is to really increase the knowledge about Huntington's disease, both among Huntington's disease families, but also among our colleagues in different professions, because I often feel that's really lacking in Sweden, both, as you were hearing, the families come to different clinicians and they know very little about it. It's really important also to remember there's actually pretty good symptom-reducing treatment, and it's important that the patients receive the correct one. And also one can do a lot of things with good care. So the clinical diagnosis today of Huntington's disease is when somebody manifests with typical motor symptoms, chorea, in combination of a positive gene test. And that has put Huntington's disease among the group of movement disorders with Parkinson's disease and similar disorder. And it has typically a prevalence of 1 in 10,000, although there are some reports coming up that potentially the prevalence may be more. So the motor symptoms, so it's also important to remember that around 90% of the patients will manifest with chorea, these involuntary extra movements. And for those symptoms, we have pharmaceutical treatment available. But people can also manifest with only bradykinesia or dystonia, or sometimes almost no motor symptoms at all. And we know today that before motor onset, cognitive psychiatric symptoms are very common. I cannot emphasize it enough. We have heard it several times. And also brain atrophy can be present and seen using magnetic resonance imaging over 15 years before motor onset, meaning that when somebody manifests with motor symptoms, they can be pretty well into their disease. So when it comes to the cognitive symptoms, they are early and common, and sometimes they can be confused with what other professionals may consider being a neuropsychiatric disorder, but we know they never manifest in adulthood, they always come very early on in life. But it's because the symptoms that ADHD patients can manifest with can resemble neuropsychiatric disorders, such as maybe high-functioning autism spectrum disorders, ADHD, and so forth. And so the cognitive symptoms are really the ones of frontal dysfunction, such as executive dysfunction, and people can manifest with reduced capacity of organization and planning, reduced attention and concentration, reduced mental flexibility, often reduced insight into their problems, and a lack of impulse control. And of course, this can create a lot of problems in carrying out your daily life as well as your social relationships. The psychiatric symptoms are also early and common, and they can really vary. Depending on which study you look at and what kind of scales they've been using, they can be vary in degree. Some people will not have psychiatric symptoms, but many will. And so out of the ones, the most common ones are things like depression, suicidal ideation, that I'll get back to, apathy, irritability, anxiety, OCD, as well as psychosis, which is always very apparent when it manifests, but is really not one of the most common psychiatric symptoms in HD. I like to just focus a little bit on apathy. That's a psychiatric symptom that may come one of the earliest one, and it's really the only one that really progresses with the disease. And therefore it could be particularly important in understanding the neurobiological mechanism of apathy, as it may have something to do with the disease progression and pathogenesis in itself. It's worth to say a few words about suicidality in Huntington's disease. There's a higher risk of suicide among the people affected by HD than in the general population. It's been estimated to around 6%. It's been shown in studies that the risk is particularly increased just prior to motor diagnosis, or when the independence is threatened and the person is more and more dependent on other people's care and help. And so suicidal ideation in the prodromal phase is around 10% of people would have that, and 20% in the motor phase. And just like for the general population or people in psychiatry, it's associated to depression and anxiety that we can treat for the most part, and also to intake and alcohol and drugs. And these are really things where we can intervene and help these individuals. So here I show cute babies, but I also show the facial expression of emotion, which is something we're all born with to express and to interpret. The positive emotions of curiosity and happiness, the neutral emotion of surprise, and all the negative emotions of shame and disgust and anger and sadness. And the interpretation of facial expression emotions, that's something that's been repeatedly found in different studies looking at prodromal HD that is affected. And of course, it's easy to imagine how that really affects a person's social capacity when the ability to interpret other people's facial expression is affected. And potentially that can be part of what's perceived as a personality change in someone affected by HD. What's also important to know about and to treat are sleep problems. So these are early symptoms, common in the general population, but we also know that all kind of problems with sleep heavily contribute to the manifestation of cognitive problems as well as psychiatric symptoms. And we know that patients with HD have a disturbed circadian rhythm. And interestingly, studies in Huntington's disease mice have shown that if one can improve the sleep, improve the circadian rhythm, that will actually reduce the disease burden in the mice. So even more important to actually help patients with HD to sleep better using sleep hygiene measures or pharmacological treatments. A few words on metabolic changes. That was one of the observations we made early on in Venezuela. There were some families with more chubby body composition, and they tended to have a much more slower disease progression. And that's been now shown in a number of studies. The people who have a higher BMI at motor onset actually have a slower disease progression. And that's why I think it's interesting to understand what are the underlying neurobiological mechanisms for that. And I always advise my patients, even the ones who are who have a bit more weight, not to trying to lose that. However, we know that in later stages, patients lose weight, and that's important to prevent. And interestingly, there's something about the regulation of Huntington and metabolism, because almost all mice that we have engineered in the laboratories have metabolic dysfunction. So the treatment of Huntington's disease today, it's important to emphasize we have effective pharmacological treatment against motor and psychiatric symptoms. There's a real importance in reducing stress, because that's the factor that has the most impact on the cognitive dysfunction. There's a really good effect of care, and there's a real importance in having access to a specialized multidisciplinary HD team. So the pharmacological treatment of HD, so what really, the treatments that only have the only ones that have evidence for HD, but it's also because they've been particularly tested for that, are the tetrabenazine and deutetrabenazine that we heard about. They act on the VMAT2, which is affecting the release of dopamine in the synapse, but also serotonin. And potentially that's why that the major side effect of tetrabenazine is depression and suicidal ideation, and therefore not a good treatment for somebody who has psychiatric problems. And as a psychiatrist, I'm not a favor of tetrabenazine at all. For motor symptoms, I prefer to use atypical neuroleptics. And when it comes to like a standardization of treatments and so, we don't have a lot of evidence, but there have been published guidelines based on experts' surveys and so on, and there the recommendation is really tetrabenazine or atypical neuroleptics. The ones that are most commonly used, most effective, are risperidone and olanzapine, and they usually have other effects, sometimes side effects, but they can actually be beneficial for HD patients, as they can also promote sleep and potentially a bit of weight gain that sometimes is good for people who don't have appetite or lose too much weight. For psychiatric symptoms, we use all the treatment that we commonly use in psychiatry, and particularly SSRI and sertraline has a fast and really good effect on irritability. And my experience is that SSRI work much better in HD patients than in other people with depression and anxiety and other problems. And for more severe problems, the common use is atypical neuroleptics. And for sleep disturbances is also the different type of sleep medicine that we have available. So the other part of the treatment is really the access to the multidisciplinary team for HD that should preferably consist, I think, both of a psychiatrist and a neurologist, as well as a neuropsychologist, not least for examining what is the status of the cognitive changes, which is important for sick leave and those kind of measures. There also needs to be a nurse and a social worker, occupational therapist, physiotherapist, speech therapist, dietitian, as well as clinical geneticist and genetic counselor. And so in Lund, we have had a multidisciplinary team for over 20 years, and last year we managed to get the Lund University as well as our healthcare organization to take the initiative to forming an excellence center of Huntington's disease to really improve care in HD, but also bring research closer to the clinic. And so we're currently developing the center where we're building on the already existing multidisciplinary team, but we now have much more access to offer, and I also run a clinic every week, because I think in many teams there's a lack of a psychiatrist, and often they are handled only in the neurology clinic. And just like in Ireland, I mean, Sweden has a lack of neurologists, and they have very little time. So I think this is really great, and what we're also trying to do is to work closer with clinical genetics and having people who get tested for the HD gene to immediately offer them a follow-up. And not so rarely there are actually symptoms to treat and help these patients with so early on, not surprisingly knowing how early psychiatric and cognitive symptoms begin. So we also have a vision to form a national competence center And we like to facilitate both translational research as well as clinical studies and trials. And just like in Ireland, Sweden is not yet part of enroll HD because of the GPDR laws and implementations. We have had difficulties getting the ethical permit in Sweden. And so the vision is really to have, so this is Sweden, and to have the yellow area, which is the southern part of Sweden, one of the more populated area of Sweden, of all of patients in this area to come to our center, and the uptake area is around 1.8 million. So that's what we're working for currently. But so clearly, more research is needed for Huntington's disease, and as been mentioned, we are in a privileged position. We know the gene that's causing the disease and is responsible for the onset of the disease. So what do we know about this Huntington protein that is causing the disease? It's a bit of an enigma, I always thought, because it's ubiquitously expressed in all cells of the body. It has critical functions during the embryo. All mice without Huntington die during the embryonic stage, and it has critical important functions in some cells. And it's thought to lead to a toxic new gain of function that we don't fully understand, and potentially there's also loss of function. And what's known inside the brains, those little dark dots, are these aggregates of Huntington forming in the brains of Huntington's disease patients. What's special, though, is that although this mutant Huntington protein is expressed everywhere, there are just some cells that are particularly sensitive. And so here is a brain of somebody who died of Huntington's disease at end stage, and you can appreciate that there is an atrophy, there is a reduction in the cerebral cortex, probably being responsible for some of the cognitive symptoms, and there's a clear reduction of what's called the striatum of the basal ganglia, one of the motor centers. That's this area around the ventricles in the middle of the brain. So there's something that makes certain neurons much more sensitive to Huntington. So we know quite well that the basal ganglia is responsible for the motor symptoms. The frontal cortex and the changes there could be responsible for the cognitive symptoms, but we know much less about the early psychiatric symptoms and the sleep and metabolic disturbances. And so these come 10 to 15 or 20 years before motor onset. And so understanding the neurobiological mechanism of these early symptoms could potentially reveal new targets for therapies for HD. And so these functions are not typically controlled by the basal ganglia or the frontal cortex in the brain, but instead they could potentially be controlled by the small area in the middle of the brain, the hormone central hypothalamus. And that's a hypothesis we have in my research group. And so we're hypothesizing that there's something about mutant Huntington that makes the hypothalamus particularly sensitive, which can then lead to these non-motor symptoms. And so in the laboratory, we're tackling this question by looking at MRI from living patients, from brains, from people who donated their brains for research, dying from Huntington's disease, as well as different biofluids and mouse models. And so the hypothalamus, not very known to many people, controls emotion, sleep, and metabolism. It's well known, though, to control the different endocrine axes in the brain, but it also has many different neuropeptide populations that project throughout the brain, controlling these other functions. And so we know hypothalamus is involved in things that are altered in Huntington's disease, such as energy metabolism, and stress, emotion, reward, circadian rhythm, and sleep. It's a complicated area. Here you see hypothalamus really enlarged, but colored with blue because cells are otherwise normally don't have any color. So this is a hypothalamus, usually the size of a sugar piece that you would put in coffee. And the cartoon to the right just shows the complexity of the hypothalamus with the different nuclei being interconnected. And so when we started this work more than 10 years ago, we found that there was a loss of a neuropeptide here called orexin or hypocretin. And here is one of my previous PhD students, Sanas, who's been conducting some of this work. And you can see these black dots are colored cells, and there are much less in the HD part. And so orexin is interesting. This is really also one of the neuropeptides involved in both the control of the sleep-wake cycle, emotions, and body weight, and it's been heavily studied today for different types of neuropsychiatric disorders. We also found loss of the neuropeptides oxytocin and vasopressin with a 45% reduction of oxytocin and 24% reduction in vasopressin. And so these neuropeptides are interesting. Oxytocin is important for social cognition and for the experience and reward in social contexts, and is also being heavily studied for neuropsychiatric disorders, as well as vasopressin, which has a potentially an opposing role to oxytocin in social cognition, being suggested to be involved in aggression. And in fact, there is an ongoing trial, as we're speaking, looking at and targeting the vasopressin system to treat irritability for Huntington's disease. This is a program that's going on in the US currently. And what's interestingly is that oxytocin and vasopressin are involved in our capacity to recognize facial expression of emotions. And so we're speculating that the effects on oxytocin and vasopressin could potentially play a role in the reduced ability to recognize facial expression of emotions that's occurring early on in HD. So then you wonder, how early is hypothalamus affected? And so that's difficult to study in the sense that there are very few brains in brain banks donated from people at early stage because they live, fortunately. But we got hold of a case of somebody who died early on, who only had sleep and anxiety manifestations, not yet motor symptoms, who died from a cardiac problem, and who donated his brain for research. And so here is somebody, you can see the brain up on the top, somebody who doesn't have striatal pathology, who did not have motor symptoms. And when we looked into that person's hypothalamus, we could indeed see that the oxytocin and vasopressin system were affected already at this stage, really driving us forward in trying to understand if these changes could be involved in these early psychiatric symptoms. So of course, in postmortem material, you can only do descriptive analysis, and we are interested in understanding, could changes in the hypothalamus affect the development of these non-motor features? And so in order to do that, we have to look at some of our animal models and the psychiatric aspects of them. And so here are the most commonly used tests in mice that we have used to develop the treatments we have today in psychiatry. Here is a sucrose preference test to the left. A mouse can choose between sugar water and regular water, and is thought to be depressed if it doesn't want to drink the sugar water but drinks equal amount of both. Then you have the Porcel 4 swim test when the mouse swims, only for 6 minutes after ethical permit, and if they just float around, it's considered as behavioral despair, one part of depression. And to the right, you have the elevated plus maze looking at anxiety-like behavior, where the mouse can choose to be out on the curious, open areas or hiding in the dark, safe corridors. And so in the laboratory, we can look at HD mice that grow up in exactly the same environment as their wild-type siblings who don't have the gene. And when one of my previous PhD students looked at that, she could see that only the presence of the Huntington's disease gene in these mice make them develop a psychiatric-like behavior with the depressive-like features and anxiety-like features in the test that I just described. And so in this model, called the back HD mice, we can now treat them with some of these different neuropeptides. And here's one of my postdoc, Rachel Chong, who treated some of these mice with oxytocin and then prevented the depression. This is just a little teaser of our ongoing work. Similarly, these mice are engineered in a way that we can inject viral vectors in the mice in the hypothalamus and inactivate mutant huntingtin, stop mutant huntingtin only in the hypothalamus, and then you can see that this depressive-like behavior is prevented. Also shown here in a bit of an easier sketch, meaning that you get less depression after some kind of a gene therapy in the hypothalamus in HD mice, providing a causal link between hypothalamic changes and depressive-like features in HD mice. So future therapies, as we heard previously very well from Lauren, is likely to contain something about gene therapy or other Huntington lowering strategies. And so here is just my sketch coming from Sweden with IKEA. Do you have IKEA? Do you have the Billy bookcase? Yeah, that's usually what I use. And so, of course, for Huntington's disease, we have great capacity to reduce Huntington. And so currently, as we heard, there are trials ongoing trying to reduce mRNA in different ways, and there are more trials coming up trying to target these different pathways in different ways. So these are very promising times. So to summarize, Huntington's disease is really a complex brain disorder. It's always caused by CAG repeat expansion in the Huntington gene, so we have an advantage compared to many other disorders. It's really a triad, and we need to really look at that, everyone. It's both psychiatric, cognitive, not only motor symptoms that are important, and that there are really effective symptomatic treatments to some of these symptoms today. And we hope that future therapies may include Huntington-lowering molecules or other targets affecting the neuronal pathways affected in HD. So finally, I'd like to thank my research group in Lund and my collaborators, important funding agents in Sweden and elsewhere, the important brain banks that are really critical for us to do such research studies in brains of people affected. And I also like to thank all the HD families that I see for continuous inspiration and motivation. And thank you for your attention.